Good morning, colleagues. So, today I will be dealing with diagnosis and medical management of ocular surface disorders. So as we know, the ocular surface comprises of the mucosa, which starts from the lid margin, includes the entire conjunctiva, limbus, and corneal epithelium, along with the tear film. The disorders of ocular surface are numerous, but I will restrict myself to the meibomian gland dysfunction, since this is a very important component of evaporative dry eye and which is of relevance to every general ophthalmologist. Before going ahead with the MGD, just a quick revision of the tear film. As we know, it is made up of three components. Though the main component is aqueous, which is the main bulk, but it is the overlying lipid generated by meibomian glands which prevents the evaporation of the tear film. So lipids are essential for maintenance of tear film. That is why dry eye is broadly divided into two types. One, the aqueous deficient, and the second is the evaporative. And in evaporative type of dry eye, meibomian oil deficiency constitutes one important component. And this is the reason that there was a special international workshop to study the role of meibomian glands, and they came out with their recommendations in 2011. They gave this definition of meibomian gland disease, in which the glands are chronically affected, and they gave us a management algorithm which we can follow in our general OPD. So my talk will be based mainly on the recommendations of this workshop. So what they have suggested is that in our routine OPD, every general ophthalmologist can easily use these tests. First is just eliciting the symptoms. Most of the times, the symptoms of dry eye are quite vague. They may be like irritation, foreign body sensation, grittiness, blurring of vision, or heaviness. So once we have noted down the symptoms, the next step is noting down the lower tear meniscus, then tear film breakup time, then the staining of ocular surface, Schirmer, and last comes the documentation of meibomian gland dysfunction. So coming one by one to these, once symptoms have been noted down, pay attention to lower tear meniscus. Normal meniscus height is around 0.3 to 1 millimeter, but this froth is quite a pathognomic sign of meibomian gland dysfunction. So this must be noted down. Then comes the tear film breakup time. As we know, if we instill fluorescent into eye, there is a uniform green color which we can visualize. However, these black spots, when they appear, it means that tear film is getting broken down at these points. And thus, tear film breakup time is an important parameter in evaporative dry eye. How I do it in my OPD is I wet the fluorescent strip with distilled water. I put one drop into patient's eye, ask the patient to blink 2-3 times so that it gets equally distributed. Then I ask the patient to open eye, and the time from opening eye to appearance of these black spots is noted. So a normal tear film is stable for 10 seconds to up to 200 seconds. But if the tear film is getting broken down before 10 seconds, it is quite significant. It is pathognomic. Then once we have done with the tear film breakup time, we see what is the staining of the ocular surface, and this we can document in our OPD papers, that what is the extent of corneal and conjunctival involvement. Schirmer's we are aware. Last comes documentation, how meibomian gland dysfunction is present. So before going with the dysfunction, we must be knowing how a normal meibomian glands look like. They are round or oval, very small orifices, around 30-40 in the upper lid, around 20 in the lower lid. And when we press them, very clear secretions come out easily. However, When there is a disease state, we will find that we will have difficulty in expressing out those secretions. Second point is that secretions won't be clear. They will be slightly turbid. According to the increase in turbidity, they become very opaque in severe cases, and in grade 4, they become just like a toothpaste, which come out with very difficulty. Another point suggestive of meibomian gland dysfunction is that the lower lid margin, which should be ideally smooth, it will become irregular, bumpy, or we can find a meibomian gland capping, or telangiectasia, means that there will be multiple blood vessels around the orifices. All these are suggestive of a meibomian gland dysfunction. So once we have noted down all these, they will help us. No doubt, there is slight difficulty in evaporative dry eye, that many patients will have features which are combined for aqueous deficiency as well as evaporative. And no doubt that the symptoms almost remain same in both kinds of dry eye. One difference is definitely that in many patients with evaporative dry eye, they rather complain of watering. Because the tear film quality is bad, eye tries to compensate it by increasing the quantity of lacrimal fluid. So sometimes in evaporative dry eye, it is the reverse kind of phenomena. Ocular surface staining can be seen in both. The only things which are more suggestive of evaporative dry eye is that in these patients, Shermer score is normal, but tear film breakup time is low, and meibomian gland dysfunction is there. So if we find that in our patient, these last 4 points are there, means Shermer score high, meibomian gland dysfunction, and low tear film breakup time, these are more suggestive of a evaporative dry eye. And how it translates into our general practice is that in an aqueous deficient dry eye patient, our main emphasis is only on the lubrication part or punctal plug, those kind of things. In an evaporative dry eye, unless we treat this MGD component, patient won't get the relief. And this is quite common in our post-cataract surgery patients also. Let's see by this one example. This is a young girl, 15 years. She was having complaint of irritation for 2 months, and she was being treated just like for conjunctivitis with mild antibiotic and lubrication. The point which was being missed is that her lower lid margin was very irregular. You can see these secretions are turbid, quite turbid. And the point which was missed is this is the ocular surface. So she was a patient of a meibomian gland dysfunction associated evaporative dry eye. So this is the reason that MGD is very common but missed. And according to the recommendations of the international workshop, they have given us 4 stages of MGD and accordingly told us the treatment part. Stage 1 is that in which patient is walking to your OPD, he is having no symptoms of dry eye, but when you see the lid margins, you feel that there are some signs of MGD. In such patients, you can just inform the patient about the importance of lids, and that in case he gets the features, patient can come to you. More common in the stage 2, in which there are symptoms, there are some signs of MGD, though there is no ocular surface staining. In these patients, mainstay of treatment is warm compresses and lid massage. Warm compresses should be for 5 to 15 minutes. Temperature should be around 40 degrees, and it should be done once or twice. In addition, we can add topical azithromycin eye drops twice a day. Lubrication should be depending upon the symptoms and associated aqueous deficiency. Stage 3 is that in which we get the ocular surface staining also. So in these patients, in addition to warm compressin and azithromycins, we add the oral doxycycline. And last is the stage 4, in which secretions are very turbid, in which we need additional anti-inflammatory therapy also. I will give just one example of this stage 4. This is a young patient, 25-year male. This is the right eye of the patient. We can see the secretions are opaque. There is telangiectasia. Conjunctiva is diffusely congested. Cornea is showing a small central epithelial defect, but there is central sphere edema with cellular infiltration, which is not infective in origin. The other eye is also congested. So this patient with meibomitis more in the right than left with keratitis is even suggestive of maybe rosacea, in which stage 4 MGD is very common. So I took the retrospective history. His eyes were red since early childhood, malar erythema, and in past he was treated with steroids. Once even antivirals were considered for him. But for this, he was put on doxycycline, prednisolone, antibiotic therapy along with hot compresses lid massage. This is the picture after 2 weeks. This is the picture after 8 weeks. And this MGD is not restricted to adult population. You will see it even in children less than 5 years of age. This 1.5-year-old child, they don't show you on the slit lamp, but then you have to see right eyelid is appearing normal, left eye lower lid is bulky. If you avert, multiple ruptured granulomas are visible. Same, sometimes we treat them just like allergy because they show the thickened lids and the redness part, but these patients, they respond very well to meibomian gland treatment. So just summarizing that MGD is very common. It is thought to be rather the most underdiagnosed and most undertreated ocular surface disorder. So if we pay attention to the lids and incorporate tear film breakup time in our daily practice, it will be of immense help to our general OPD patients. Thanks.